foreign bodies are parts or chips of iron and steel, particles of glass, stone, plastic, and wood. All foreign bodies may be classified as magnetic and non-magnetic. It's necessary for the principles of their treatment, of their removing. How to put the correct diagnosis? History, to determine type of foreign body. If you know the history, if you know if your patient can explain what's happened, you can make a suggestion about the type of intraocular foreign body. Then ocular examination, due to the general principles of examination of the eye, and then ultrasound and X-ray examination, which can help us to determine the presence of intraocular foreign body, and not only presence or absence, but also its localization. In case of, here you see one of the example of X-ray examination, and we can see in the orbit, in the projection of orbit, we can see the presence of foreign body, but we can't say due to this one picture, we can't make a conclusion about the position of foreign body. Is it in the orbit, or maybe in front of the orbit on the surface of the eyelid, or behind the orbit in the brain, and it's neurosurgical but not ophthalmological pathology. So it depends. And for more thorough examination, we use special tests, the so-called, in our country we use Comberg-Belton examination. When we make two X-ray examinations and two projections, in the anterior and in lateral, and we use special indicator, special aluminum indicator. And two exposures, as I said, are taken in the anteroposterior view and in the lateral view. And special scheme is used to localize the intraocular foreign body, and I hope that during our practical classes we'll discuss more thoroughly how to differentiate, how to localize the foreign bodies. Bone-free X-rays are used to determine the position of non-metal, glass or wood foreign bodies, and also ultrasonography and of course computed tomography scans is useful in diagnosis of intraocular foreign bodies. Be very careful with MRI, with magnetic resonance tomography, because in magnet field the metal foreign body can change its position, and you can cause additional damage of the intraocular structures. How to treat intraocular foreign bodies? Of course, intraocular foreign body should be removed. Removal of magnetic intraocular foreign bodies is easier than the removal of non-magnetic. Usually a handheld magnet is used. The way of intraocular foreign body removing depends on its localization. There are three main ways of removing of foreign bodies. Anterior, when it is situated in the anterior segment of the eye, and we can remove it through the paracentesis. For example, if it's in the anterior chamber, we make a small cut in the cornea and remove carefully. The direct, when it's located in the superficial layers, and for example, one tip of the foreign body is inside the eyeball, other tip is out of the eyeball. So like, for example, a needle. We can remove it just through the wound. But be very careful, because if it's not, the surface of the foreign body is not smooth, when you start to remove it, you can remove it together with the inner structures, and it will be loss of contents and more severe damage. So it also we should be very, very careful. And transscleral, if it's the commonest way, because most of the foreign body inside the eyeball are situated in the behind the lens, behind the iris, somewhere in the posterior part of the eyeball, and through the sclera we make a cut in sclera, and with the help of magnet or with the help of forceps, we can remove this foreign body. What are the main complications of intraocular foreign bodies and severe perforative traumas? Traumatic cataract, introduction of infection, post-traumatic iridocyclitis, it's inflammation of the uveal tract, its anterior part, and sympathetic ophthalmitis and reaction on foreign bodies. What does mean reaction on foreign body? Reaction on foreign bodies depends on type of intraocular foreign body. Usually we are talking in this case about the metal foreign bodies. For example, the most frequent type of foreign bodies, iron foreign bodies, and the complication due to its presence, long presence inside the eyeball, is named siderosis bulbi. It refers to the degenerative changes produced by an iron foreign body, and these usually occur after half a year of the injury, after 6 months of the injury. If we didn't remove foreign body in time, because of some reasons, we can find such a severe complication after half a year of its presence inside the eyeball. The iron particle undergoes electrolytic dissociation by the current of rest, and its ions are disseminated throughout the eye, and it's sort of toxic damage as a result of electrochemical reactions inside the eyeball between the iron foreign body and aggressive intraocular liquids. The anterior epithelium and capsule of the lens are involved first of all, so we can see a sort of cataract. The rusty deposits are arranged radially in a ring. The lens becomes cataractose. Iris is first stained greenish and later on turns reddish brown. The iris looks dirty, it changed its color. For example, it was blue before the trauma or gray before trauma. It will be dirty greenish after when the siderosis bulbi appears. Retina develops pigmentary degeneration with severe loss of visual functions, and then secondary open-angle glaucoma and secondary iridocyclitis may be the result of these degenerative changes. Halcosis. It refers to the specific changes produced by the presence of copper intraocular foreign body in the eyeball. Clinical features: sunflower cataract produced by deposition of copper under the posterior capsule of the lens. It is brilliant golden green in color. Retinal examination may show deposition of golden placus at the posterior pole, which reflected the light with the metallic sheath. The third possible reaction on foreign body is purulent uveitis. It is very dangerous, as I understand, as any purulent complication. It's very dangerous complication of perforative injury of the eye. It may start as a purulent anterior uveitis, iridocyclitis, or purulent posterior uveitis, choroiditis, which soon progress to involve the retina and vitreous, resulting in purulent endophthalmitis. In some cases, endophthalmitis may be caused by corneal ulcer or perforative infections following intraocular operations. It may occur rarely through bloodstream from some infected focus in the body, such as caries teeth, generalized septicemia. Causative microorganisms are Staphylococcus, Pseudomonas aeruginosa, Escherichia coli, Pneumococcus, and Streptococcus. Symptoms of purulent uveitis include severe ocular pain, redness, lacrimation, marked loss of vision, lid edema, conjunctival hemosis, edema, severe edema of the conjunctiva, marked circumciliary congestion, it means dilation of the blood vessels near the limbus, conjunctival blood vessels near the limbus, corneal edema, exudates in pupillary area, fibrin and other pupil pus in the anterior chamber. Pupils show yellow reflex due to purulent exudation in vitreous. So normally we can see the red reflex from the fundus through the pupil. In this case, it will be yellowish, dirty, whitish, grayish due to the presence of pus in the vitreous body. Treatment include broad spectrum antibiotics, topically, in form of drops, different types of injections, subconjunctival, retrobulbar, and intravitreous, and systemically. Then mydriatics, drugs which dilate the pupil and which cause the relaxation of the ciliary muscle and relieve the pain. Treatments include also corticosteroids. Enucleation, removing of the eyeball, may be performed in case the patient does not respond to the urgent intensive therapy, including vitrectomy. So if we have no other ways how to help such a patient, we should think about the removing of the eyeball. We should think about the enucleation, because spread of the infection out of the eyeball, purulent infection out of the eyeball, may cause the severe damage of the brain, purulent abscesses, meningitis, encephalitis, purulent inflammation of the brain with the real risk for the patient's life. Panophthalmitis. Pan means all, so panophthalmitis, total inflammation of all the of the whole eyeball, including the Tenon's capsule. Etiology is the same we described for endophthalmitis. It may be the next stage of previous type of inflammation of endophthalmitis if there were no treatment or treatment was not successful. The main symptoms are ocular pain and headache, complete loss of vision, profuse watering, purulent discharge, marked redness, and swelling of the eye. Associated constitutional symptoms are fever sometimes, and signs are edema and hyperemia of the lids, slight proptosis of the eyeball, ocular movements are limited and painful, hemosis of the conjunctiva. Hemosis means severe edema of the conjunctiva, mixed congestion. Cornea is cloudy and edematous, and anterior chamber is full of pus. Vision is completely lost, and perception of light is absent. Globe perforation may occur at limbus due to the resorption of the eye tissues by the aggressive purulent discharge, aggressive pus. Treatment, intensive antibacterial therapy, broad-spectrum antibiotics, anti-inflammatory drugs, and analgesics to relieve pain. Evisceration should be performed to avoid the risk of intracranial dissemination of infection. The difference between evisceration and between the enucleation: in case of enucleation, we remove all the eyeball. In case of evisceration, we remove only the contents of the eyeball and leave the outer coat of the eyeball leave sclera. So it's just after such a surgery as evisceration, eye looks like the rest of the eye looks like a empty sac consists of only outer fibrous coat sclera, and that's all. And several words about the so-called sympathetic ophthalmitis. Sympathetic ophthalmitis, it is bilateral granulomatous panuveitis, which follows a penetrating ocular trauma. very severe complication, and it may develop about from 4 to 12 weeks after either an injury or early intraocular surgery on the eye. Etiology is still not known exactly. Immune theory is maybe the most supported type of etiology, and various theories have been put forward about pathogenesis. I mean, allergic, infectious, neurogenic, and so on. So most accepted one is autoimmune and allergic theory. It is thought to be that injury to one eye results in programming of the body to produce ocular disease autoimmune T cells, T-cell lymphocytes, and their reaction in the injured and in the other eye. So a sort of autoantibodies. As the reaction on trauma, there exists production of the autoantibodies, but they damage not only the injured eye, but also the healthy, non-injured eye. So this is the most dangerous factor in case of sympathetic ophthalmitis. One eye was damaged, but in case of sympathetic ophthalmitis, patient can lose both eyes, visual function of both eyes. So signs is typical for ardesiglitis. Clinical picture. The injured eye is called exciting, and the fellow eye, which also develops uveitis, is called sympathizing or sound eye. Sympathizing eye is usually involved after 4-8 weeks of injury in the other eye. The early symptoms of sympathetic ophthalmitis are sensitivity to light, photophobia, lacrimation, sometimes rather mild lacrimation, transient indistinctness of near object, the so-called weakness of accommodation. So just rather simple symptoms, and if patient has no history of eye trauma, it's not so dangerous. But if your patient has a history of trauma of one eye and you see such symptoms on the other eye, oh, it's a very, very, very bad symptom, and you, at the same moment, you should start very thorough examination, sometimes even with the help of methods of immunohistochemical laboratory tests to prove or to exclude the diagnosis of sympathetic ophthalmitis, because treatment is very, very difficult, and corticosteroids are the main group of drugs which we use for treatment of sympathetic ophthalmitis. Also, by all routes, it may systemic periorbital injections, frequent instillation of topical corticosteroids. We use all these ways of use. Sometimes we can, in severe cases, we can use even immunosuppressive therapy with cytostatics. Also mydriatics, antibiotics, like in case of treatment of other types of uveitis. Treatment should be continued for a long period of time. Prophylaxis of sympathetic ophthalmitis, the only prophylaxis is early excision of the injured eye. It is the best way of prophylaxis to remove the injured eye and no autoimmune reaction. But of course, you understand sometimes trauma is not so severe. After the surgery, the visual functions are rather good, and how to explain the patients the necessity to remove the eye which has a good visual functions. It's difficult. It's not only a medical but also psychological problem. But now I have to say that now we live in the era of corticosteroids. We use them widely after the surgery and after the severe traumas, and the risk of sympathetic ophthalmitis very, very small. It's a very seldom complication, for example, during last 20 years of my practice, everyday practice, I saw 1 or 2 such patients. Prognosis: if sympathetic ophthalmitis is diagnosed early and immediate treatment with steroids is started, a useful vision may be obtained. However, in advanced cases, prognosis is very poor, even after the best treatment. Last but not least, for today is chemical injuries. Chemical injuries, chemical burns, are the most urgent and are caused usually by alkali and acid. They have differences in clinical pictures. So before you start your treatment, you should try to discuss with the patient and to determine what kind of chemical substance caused this injury. Alkali burns are more severe than the acid burns because of their rapid penetration, often less than 1 minute, through the cornea and anterior chamber, combining with cell membrane lipids. Damage from alkali burns is related more to degree of pH alkalinity than to the actual caution. Permanent injury is determined by the nature and concentration of the chemicals, as well as by the time elapsed before irrigation. Acid burns cause their maximum damage within the first few minutes to hours and are less progressive and less penetrative. Acid precipitates tissue proteins that rapidly set up a barrier against deep penetration by the chemical. There exists chemical coagulation, acid coagulation, and these coagulated tissues of the eye, like a border between the areas damaged by the acid and between the normal healthy areas. In case of alkali, it's a very more deep penetration, and if you look at the patient after first several, maybe 20-30 minutes after the damage, be very careful, because next several hours or even days you can see the progress of the process. In case of acid burns, if you see this patient after 2 hours after the burn, there exists very small possibility that the next day you'll see more severe damage, because it's usually non-progressive after several hours. So gradient of chemical burns, depending on their severity, there are 4 grades. The first one is hyperemia of the conjunctiva and erosion and edema of corneal epithelium. The second one, the second stage, is ischemia of the conjunctiva. Areas of clouding may appear in the cornea. May be loss of corneal sensitivity in this stage. The third stage, when we can see total corneal epithelial loss, total corneal erosion, and stromal clouding, more deep damage, and deep conjunctival necrosis and corneal necrosis. And cornea is china in color. Cornea is whitish, and in most of cases it's reversible opacity of cornea, and the only keratoplasty, transplantation of cornea, can help to repair the visual functions. What are the main complications of corneal chemical burns? Superficial neovascularization, development of symblepharon means adhesion between the conjunctiva of the eyeball and conjunctiva of the inner surface of the eyelid, recurrent corneal ulceration, complicated cataract, and secondary glaucoma. Immediate treatment includes you should wash with available clean water to remove this chemical substance, and treatment includes irrigation of antiseptic solution like furoselinum, or normal saline solution 0.9 percentage, antibacterial drops and ointment, mydriatics, analgesics, antihistamine drugs, vitamin C, like an antioxidant. Treatment of complications like corneal ulceration, complicated cataract, secondary glaucoma, symblepharon formation is surgical. There are no other ways of treatment. Additional to the chemical, there exists a group of radiation burns caused by infrared radiation, ionizing radiation, ultraviolet radiation, which cause photophthalmia. Infrared burns are usually of little consequence and produce only temporary lipedema and erythema, hemorrhage, hyperemia, but little or no damage to the globe. Chronic exposure to infrared light is seen in glass blowers and metal furnace stokers. There exist several groups of industrial workers who had a risk of damage by infrared radiation due to the constant presence in these fields. But now it was actual and important maybe half a century ago. Now it's a very, very small risk of such complication because of the good prophylaxis, use of special glasses, special industrial goggles, and the main complication of infrared burns are cataract formation, which can be treated by according to the general rules of cataract surgery. Ionizing radiation may damage the cornea, lens, uveal tract, retina, and even optic nerve. But also special screens and protective screens and glasses which can absorb this type of radiation, gamma and neuron radiation, X radiation, can help to decrease the symptoms of damage or even to prevent the damage. In acute stage, you can see hyperemia of the eyelids, or symptoms of the eyeball, radiation keratitis, latency period from 6 months to 12 years existing, depending on the dosage of ionizing radiation. And the uveal tract may undergo vascular dilation with subsequent edema. Ultraviolet radiation is the most common cause of light-induced ocular injury, not so dangerous. Photophthalmia refers to occurrence of multiple epithelial erosion due to effect of ultraviolet rays. After 4 or 5 hours latent period of exposure to ultraviolet rays, there occurs desquamation of corneal epithelium, leading to formation of multiple epithelial erosions. Clinical features severe burning pain, photophobia, lacrimation, blepharospasm, swelling of pulvital conjunctiva, conjunctival hyperemia. But a lot of complaints, but it's not so dangerous because after 1-2 days of successful and correct treatment, we have patient without any symptoms. Treatment: analgesics, topical, and if it's a severe pain, even oral. Antibiotic drops and ointment just to prevent secondary inflammation. Cold compresses. And sometimes we can use special ointments with vitamin A, for example, with hyaluronic acid to increase the speed of epithelium recovering. In 1-2 days, maximum 3 days, even the total subtotal corneal erosion will be epithelialized and it will be normal surface of the cornea. The patient should be reassured the damage is transient and that all symptoms will be gone within 1-2 days. Again, prophylaxis ultraviolet burns may be prevented by use of ordinary crown glasses or regular glass lenses as they absorb the rays. So one more time, clinical features and treatment, which we have already discussed. that's all for today. What I wanted to discuss about. If you have any questions, you can ask me now or ask in the chat or during our practical classes. And I'll try to answer all the questions. Do you have any questions now?
No, sir.
Fine. So thank you for your attention. Have a good weekend. Tomorrow is again your classes, but I hope that you'll have a good weekend and see you next week during our lectures. Thank you.
You too,
Goodbye.
sir. Thank you. До свидания.
До свидания.
Thank you, sir.
До свидания, sir. Thank you, sir. До свидания.